My dear friends, what an energetic evening today. Happy Dashera. Everyone in festive mode, but doctors pan India are looking forward to listen from CCI this evening. Welcome all. In the past 18 months, we at CCI has set a national record of conducting back-to-back webinars on every Thursday with the theme Guruvar ke Raat, Guru ke Saath. Tonight, we are connecting you with Dr. Kumar Kothapalli from Texas. He is our guru today. Dr. Kumar is a legendary in his specialty with MS PhD degree, currently working as an associate professor at Dell Medical School, the University of Texas at Austin, United States of America. He has done his master's from MS from Andhra University, Visakhapatnam, PhD from Usmania University, Hyderabad. He did his postdoctoral fellowship in genetics from Ivy League Cornell University, United States. He is a man of wisdom. He is a co-discoverer of a lot of biochemical pathways. For example, genetic polymorphism that controls the body synthesis of highly unsaturated fatty acids. He has many such discoveries. When he started looking at Google, he has got dozens of publications, and he provides his versatility is he provides diagnosis and genetic counseling to hundreds of individuals across the globe, and through dozens of lectures, and he shares his tons of wisdom through lectures to physicians, doctors, and the needy people across the globe. And I profusely thank CCI for bringing in this unique concept, a versatile concept on this evening, Dashera evening, for our CCI audience. Generally, the logins for our CCI webinar sessions are more than 1,000. Okay, looking forward. I welcome one and all delegates. Please listen to Dr. Kumar Kothapalli, our guru this night, and then please post your questions, doubts, whatever your suggestions, anything in the related to genetics, and we'll be happy to get back to you with all clarity. And Dr. Kumar was volunteering to even share the literature details on your personal email, if you can provide the email IDs to us. So with this short intro, I welcome Dr. Kumar Kothapalli to take over for the talk on harnessing harnessing medical genetics in pulmonary disorders. So we do come across a lot of very complex scenarios where genetics may be the only option for a therapeutic approach, or which can guide us in a particular direction to make our patients breathe better. With this short intro, I would like to hand over mic to Dr. Kumar Kothapalli. Dr. Kumar, floor is yours.
Good day, everyone. Today, I would like to talk about how we can use medical genetics in pulmonary disorders. I'm an associate professor at Dell Medical School at the University of Texas at Austin, USA. Every nucleated cell in human contain thread-like structures called chromosomes. In human, there are 22 autosomes. X and Y are sex chromosomes. If we see the chromosome pattern, metacentric, submetacentric, and acrocentric chromosomes are the three types in human. These are G-banded chromosomes where we see a light and dark color, where the light things are euchromatins and dark regions are like heterochromatin regions. Euchromatin regions are transcriptionally active and they contain more genes compared to the heterochromatin regions. So when we take these chromosomes, each chromosome contains several hundreds of genes, especially chromosome 1, which is the longest chromosome. It has like a centromere and 2 equal arms. That is the reason it's called metacentric chromosome. Submetacentric chromosomes, they have centromere, 1 short arm and 1 long arm. Whereas the acrocentric chromosomes, they have a centromere and we don't see much of the short arm, but we see the long arm. When we see the chromosome arms, these contain histones and the genetic material DNA, which are tightly packed. The DNA, if we see the DNA of each chromosome, there are several discrete genes, the pieces of DNA which make protein. Human genome also contains a mitochondrial DNA, which is like 16,500 base pairs. And coming to the genetic screening or genetic testing, we have 3 kinds of genetic testing paradigms, like biochemical testing, detecting levels of specific substance and enzymes, which we can see in inborn errors of metabolism. Today, I would be talking much of my aim is towards cytogenetic testing and molecular testing for pulmonary disorders. Before moving to the specifics, I would like to present some brief introduction about the cytogenetics and molecular testing, giving some examples towards pulmonary disorders. Cytogenetics, karyotyping, it's basically detecting numerical or structural chromosomal defects. For example, Down syndrome, chronic myeloid leukemia, and small cell lung cancers. Molecular testing, it depends upon the sequence of the person's DNA, if there are mutations or not in a person's DNA leading to some genetic disorders. Mostly, molecular testing are being done for the Mendelian disorders which are called single gene disorders, or sometimes, we are moving towards an era where we call genome-wide association studies for complex disorders. If we see Down syndrome, we have an additional chromosome 21. This is the most common aneuploidy seen in human defects. Here, in Turner syndrome, we are missing 1 X chromosome. This is a classical Turner syndrome like 45XO. And if we see the data, chromosomal anomalies account for 65 to 90% of first trimester pregnancy loss. Then here, structural chromosomal defects are of several types, like deletions, duplications, inversions, and translocations. This is a classical example where there is a deletion of a 5p arm, which causes a Cat-Cry syndrome. And once this arm of the chromosome is duplicated, it leads to Charcot-Marie-Tooth disease type 1. And we see inversions, especially, chromosomal inversions in couples experiencing recurrent pregnancy losses. Not all the couples, but few couples who have experienced recurrent pregnancy loss, they might have either pericentric or paracentric inversions. One of the classical examples of translocation is reciprocal translocation between chromosome 9 and 22, which causes chronic myeloid leukemia. This was discovered in 1960. It took like 41 years to make a groundbreaking drug called Gleevec, imatinib mesylate, to block this BCR-ABL translocation. Now, this is called a magic bullet drug. for the translocations, especially in CML patients. In 1982, there was a first publication showing like acquired, that means not inherited, but acquired, 3p deletion in small cell lung carcinomas. This has been seen in several small cell lung carcinoma cell lines. 12 out of 12 cell lines cultured from human small cell lung cancer tissue, and in 2-day tumor cell specimens from 3 patients. Recently, it has been, in cancer field, especially the chromosome arm aneuploidy, is becoming very important, because if chromosome arms gain or loss could lead to the prognosis of cancer patients, especially when there is a lower aneuploidy scores, they have a better prognosis. The most frequent chromosomal arm aneuploidy seen in lung carcinoma includes 7 chromosome short arm gain, 5 short arm gain, 8 chromosome long arm gain, 1 chromosome long arm gain, and 3 chromosome long arm gain. Similarly, we have seen like 3T, that means a short arm loss of chromosome 3, 8, 9, 13, 17, 18, 19. Especially, if the aneuploidy score is lower, they get good response to good or complete or partial response to anti-PD1 or PDL immune checkpoint inhibitors. So this score, aneuploidy score, can range from 0 to 39. Recent, data from Dana-Farber Cancer Institute, they show like aneuploidy scores less than or equal to 2 had significantly higher overall response rates, significantly lower progression-free survival, and significantly lower overall survival than patients with aneuploidy scores greater than 2. So, there are chromosomal analysis is a gold standard for a lot of numerical disorders and some such structural disorders, but they can't answer many things, especially microdeletion syndromes resulting from loss of small chromosome piece, or single gene disorders. There are like over 18,000 known single gene disorders where karyotyping cannot be used. So we need other specialized techniques for identifying those defects. If you come to the microdeletion syndromes, DGeorge syndrome, which occurs in 1 in 4,000 person, it is due to deletion of 22q11. That is a deletion of long arm of 22q11 region. Now, aspiration pneumonia can be one of the most complications concerned with DGeorge syndrome, and it is also associated with congenital heart defects. So in pulmonary medicine, there is data showing like, some forms of pulmonary hypertension is associated with 9q34.3 microdeletion in Cliff-Strauss syndrome, and abnormal spirometry in adults with 22q on 1.2 microdeletions have been seen. Similarly, in progressive lung disease, 11 XQ28 microdeletions are seen. Similarly, in alveolar capillary dysplasia, 16q24.1 microdeletions in the Fox gene cluster has been seen. These disorders can be, not common; they can be rare. But these are the microdeletions which we have seen in the pulmonary disorders. If we move forward, now since 2013, American College of Medical Genetics and Genomics have put forward like chromosomal microarrays as first tier test for especially developmental delay, autism spectrum disorders, congenital malformations, and in even prenatal diagnosis. Since 2013, there has been an update in 2021, a revision saying that chromosomal microarray analysis, which includes constitutional is like developmental delay, autism spectrum disorders, congenital anomalies, and prenatal diagnosis, as well as neoplastic diseases, Neoplastic disease, both hematological and solid tumors, which includes. So the chromosomal microarray analysis is getting very popular. And recently, data from All India Institute of Medical Sciences, they have shown by using array-based comparative genomic hybridization that chromosomal aberrations in COPD. It's a preliminary study, and we need more study on that aspect. If we move towards gene mutations, gene mutations can be inherited. That means it is passed from parents to offspring, and they are germline. Whereas acquired, these mutations, they occur in the DNA during their lifetime, and due to environmental factors and lifestyle factors, they are called somatic mutations. And they are due to environmental factors and faulty DNA replication mechanisms. These somatic mutations have been seen in several cancer types, including lung cancers. In 2003, Human Genome Project, it has shown that all diseases have a genetic component were inherited or acquired. If we see the pattern of genetic inheritance, mostly, we see Mendelian and non-Mendelian patterns. In the Mendelian patterns, autosomal dominant disorders, they have only one. If we inherit one copy of the gene, defect gene from any of the parents, one parent, it causes a dominant disorder. In autosomal recessive, we need to inherit both the copies, alleles from our parents to get the disease. In imprinting disorders, these are mainly due to, DNA methylation, that is epigenetic change and histone modifications. Classical examples include Angelman and Prader-Willi syndrome. Mitochondrial inheritance, now it's gaining traction, and we are seeing mutations in DNA. For example, certain disorders like Kearns-Sayre syndrome and Leigh syndrome, we see mitochondrial DNA mutations. Especially multifactorial disorders, they are polygenic, and environmental factors also play a big role. Asthma is one such example where, pinpointing a functional or a causal genetic variation is very difficult. There are some sporadic disorders, for example, early onset Alzheimer's disease and certain types of Huntington's chorea, they are sporadic. Contiguous gene syndromes are like small deletions or duplication syndromes. These are due to the gain or loss of chromosomal arms. So, if we see sickle cell anemia, which is one of the classical single gene disorder, where a single base pair, replacement from A to T causes sickle cell anemia. For example, in normal phenotype, we see a donut-shaped hemoglobin. In sickling, you see a sickling phenotype. This is due to a glutamic acid being replaced by valine at E6V, codon 6. This causes sickle cell anemia. Similarly, we can find autosomal recessive, autosomal dominant disorders that are responsible for pulmonary conditions. So here, if we see the genetic interstitial lung disease, there are autosomal recessive and autosomal dominant types, especially in genes in the surfactant pathway. This SFTPB gene mutations, they are autosomally recessively inherited, which causes neonatal respiratory failure. Whereas autosomal dominant disorders like SFTPC in this gene, mutations, they might cause ILD and TAP. This is pulmonary alveolar proteinosis. If we see the familial pulmonary fibrosis patterns, these are telomere genes. Mutations in these genes, they can cause, these familial pulmonary fibrosis disorders. Here is a CT scan from 3 different individuals having mutations in third, telomerase reverse transcriptase gene. All these 3 individuals, they show a heterogeneous pattern when coming to the CT scans. For example, if we see A and B, a pattern typical of usual interstitial pneumonia with peripheral, basal, predominant fibrosis and moderate to severe honeycombing is seen. Whereas in the C and D, honeycombing is not present. Whereas E and F, it is a pattern atypical of UIP. We see that. When coming to risk factor for pulmonary embolism, factor V Leiden mutations have been reported worldwide to be associated with venous thrombosis and pulmonary embolism. We see in the Indian population, up to 1.3 to 5% are heterozygous for factor V Leiden mutation, which is a single point mutation, again, G to A transition at the nucleotide position 1691. Here, the carriers, G to A heterozygotes, they have 4 to 7-fold thrombotic risk, lifetime risk for thrombosis, whereas AA homozygous individuals, homozygosity for factor V Leiden is rare, not common, and these individuals, they show 50 to 80-fold thrombosis lifelong risk time. And factor V accounts for up to 90 to 95 cases, it results in activated protein C resistance. And this mutation carriers, when they are on oral contraceptives, the risk for thrombosis increases by 15 to 30-fold, whereas it is very high in the homozygous individuals. Cystic fibrosis is an autosomal recessive disorder. 1,700 mutations have been found throughout the world. If we see here truncated mutations like G542X, these truncated mutations, they cause a lot of, there is no function of CFTR protein in these individuals. And F508 deletion is very common, up to 80%, 70 to 80% of cystic fibrosis patients, they carry this mutation. Again, this is caused due to misfolding protein. G551B, this is due to the blockage of the channels. And here the channel is okay, but R117H is also very commonly seen in certain cohorts in Europe, especially in Jewish population. And these are all the mutations that has been seen in CFTR gene, which is on chromosome 7. So why genetic testing is important? Because as we move towards precision medicine, more and more drugs are getting approved if we know a target mutation. So for example, if we see G551D mutation, in 2012, FDA fast-tracked Kydeco for the treatment of cystic fibrosis patients ages 6 and older. In 2019, same, Kydeco was approved for 12-month and older patients with 38 known CFTR mutations. So, the same drug which was approved for G551D, now if we know the mutation, these all mutations work for this particular medication. F508 deletion CFTR accounts for 70% of CFTR function loss, and it's seen in 80% of the CF patients worldwide. But this Kydeco is not approved for F508del. In 2019, Trikafta, FDA approved Trikafta for F508 deletion. So by knowing the particular mutations, now as the precision medicine is moving towards more and more targeted therapies, this is how a genetic testing can be useful. So if we see alpha-1 antitrypsin deficiency, this is inherited as an autosomal codominant trait due to mutations in SERPIN A1 or AAT gene. The most common alleles that are mutant alleles that are seen throughout the world are Z and S alleles, which are not that much common in Indian cohorts. But in Indian cohorts, like 8% of the children, they show ATT serum level deficiency or the deficiencies. And in Indian cohorts, there are new mutations. Novel mutations are found in SERPIN gene, SERPIN A1 gene. Similarly, a study from Ajit, it has shown that common and novel genetic variations in Indian samples. So, if we see like American Thoracic Society or American College of Chest Physicians, they recommend in COPD patients screening for alpha-1 antitrypsin deficiency because it is in 90% of the cases it is being underdiagnosed. If we go with the pulmonary arterial hypertension, there is a recent article showing when to offer genetic testing for pulmonary arterial hypertension. For this, we need the mode of inheritance because PAH is inherited as an autosomal dominant trait, whereas EIF2AK4 related pulmonary veno-ocular disease is autosomal recessive. So Invitae has come up with a 12 gene panel, detecting genetic mutations in these 12 genes for PAH and, pulmonary veno-ocular diseases. So if we see this abstract, it says genetic testing is poised to play a great role in the diagnosis and management of pulmonary arterial hypertension. Physicians who manage PAH should know the heritable PAH phenotypes, inheritance patterns, and responsible genes. So by knowing this, we can do better genetic counseling and better therapy for the patients. And coming to asthma is a lot of things have been done for asthma, a lot of research, and it runs in families. But asthma is a complex disorder with polygenic inheritance. And polygenic, a lot of genes are involved, and it's multifactorial disorder. If we see some genome-wide association studies, a recent review shows that some of the genes that are being associated with asthma were also found to be associated with some other disorders like rheumatoid arthritis, diabetes, and inflammatory bowel disease. And it is also seen in hypertonia, some of the genes, and in celiac disease. So pinpointing a functional variant or a causal variant to one particular gene for asthma is not possible because of its polygenic nature. And even lifestyle changes matters also for controlling the asthma, even if we find a causal genetic locus. So if we see the cancers, there was a publication in Nature in 2010 showing that all cancers carry somatic mutations. So germline mutations or germline cancers only occur in 10% of the cases, but majority of the solid tumors are due to somatic mutations. So if we see a paradigm which has been followed since 2009, which was published in Journal of Clinical Oncology from Hahn and Pao, it shows that this is the paradigm for non-small cell cancer treatment. This is the genetic paradigm where initially, the patients were screened for Keras gene test, and if it is negative, the EGFR gene test was done. If it is positive, cytogenetic chemotherapy, because targeting Keras gene is really tough. Then, if EGFR is negative, EML4 and ALK gene fusion test was done. And if it is positive, there are several EGF tyrosine kinase inhibitors like Giftinib and Erlotinib. Similarly, there is an acquired resistance, and there is now a targeted drug for this also. And if ALK is negative, some other driver mutations are being screened, and then if it is ALK positive, ALK kinase inhibitors are prescribed for these patients. Keras mutation is, if we see the Keras mutation, it has been seen in smokers, active smokers, and, the smokers who quit smoking. And it is, the data shows like it is not that frequent in non-smokers. So this Keras mutation, G12 in the codon region, G12, there is one point mutation. It is seen in up to 13% of patients. Recently, FDA approved Lumacras. It's a first-line therapy designed for patients with Keras G12C mutation. So, EGFR inhibitors have very limited efficacy in patients with Keras mutation positive patients. Yeah, EGFR inhibitors work best when there is a wild type Keras gene. So EGFR mutations are mostly seen in Asian populations. The Keras are not that much. Keras is seen in Western population more frequently than the Asian population. In Asians, we see EGFR mutations. Here, if we see the pattern of CT images, we see miliary metastasis in cases of non-small lung carcinoma with EGFR mutations. So now artificial intelligence is becoming, one of the advanced tools or designs where we can try to identify the CT images for a particular mutation type. This miliary metastasis here, if we see, it can sometimes be seen in miliary tuberculosis also. So, genetic testing will certainly identify that this kind of images are due to EGFR mutation leading cancers. Another gene that has been seen in lung cancers in up to 2 to 3% is a PIK3CA. This is phosphatidylinositol kinase catalytic domain A mutation, and it is seen in a large number of squamous cell carcinomas and very little in adenocarcinomas. So there are 3 hotspot mutations in PIK3 region, and E545K is the most frequent one in lung carcinomas. In 2012, there was a paper in New England Journal of Medicine showing that aspirin increases survival greater than 84% in PIK3CA mutation positive patients. These are colorectal cancer patients. And aspirin, there are certain papers for lung cancers also which are related to aspirin. So, we need more data on this, if PIK3 particular mutations respond well to aspirin. BRAF is another, driver mutation that has been seen mostly in melanomas, but it has been seen in non-small cell lung cancers also in up to 1 to 4%. Zelboraf is the drug which was approved in 2011 for melanoma patients, but in 2013, tremelimumab was approved by FDA for V600E as well as V600K BARF mutations. Very recently, FDA in 2017, it has approved dabrafenib and trametinib combination for metastatic non-small cell lung carcinomas with BRAF V600E mutation. So, how this precision oncology future is now, till recently, we were screening only one driver mutation at a time. But for example, if we prescribe Keras mutation, if the patient turns out to be positive for BRAF or PIK3CA, we are missing a lot of time. So now the future is to do a panel screen for all the genes that are involved in this pathway, and to give a report in one day. So OncoMine is coming up with this kind of a design where we might have a setup where we can give a report for multiple targets in a single day. So now it's a dream, but in future we might see these kind of setups coming up for precision oncology, for patients and first line therapy. And now I will move towards mitochondrial mutations after talking about a lot of examples for pulmonary disorders with gene mutations and cytogenetic defects. Mitochondrial defects are, it's a mitochondrial genome is very small, only 16,500 base pairs with 37 genes, 13 are protein coding and 24 are tRNA and rRNA genes. So recently there has been some studies showing that not the inherited but acquired mitochondrial DNA mutations are identified in lung fibrotic disorders, both idiopathic and connective tissue disease. So a lot of research need to be done in this aspect, in pulmonary medicine towards mitochondrial disorder, mutation screening. So now I will move towards, during last part of my talk, I would like to focus on the pharmacogenetics part, because FDA recently, if we see the FDA pharmacogenetic biomarker database, there are over 500 medications where FDA listing whether either boxed warnings, because some of the genetic variants in these drug metabolizing genes, they do affect how our drugs are getting metabolized. So individuals respond differently to the same medication. Adverse drug reactions are very common and they can be life-threatening. And inter-individual variations to drug responses are mainly due to their genetic makeup in the drug metabolizing genes. For example, the class 1 and class 2, which I will be talking in my next slide. And the pharmacogenomics is the area where, some of these things can be rectified, or RNA drugs can be prescribed for the people who are not responding to a drug that has been prescribed commonly for many of the disorders. So if we see here, there are phase 1 and phase 2 genes that break down the drugs, mostly CYP enzymes. There are 57 CYP enzymes in human, and they break down up to 75% of the drugs. Genetic variations in some of these drugs, they cause, different types of metabolizers, like poor metabolizers, intermediate, fast, and ultra fast metabolizer phenotypes. So if we see here in asthma, beta agonist drugs, there has been data showing like rate of poor responses in 40 to 75% of the cases. Similarly, in other disorders, we see poor responses for certain drugs. So from the FDA database, I have collected some of the drugs that have a pulmonary connection, where, if we see genetic polymorphisms in some of these drug metabolizing genes, we might see, poor responses in some of the individuals who are not responding well to these drugs. And recently there are several companies coming up with both screening the ADME. This is absorption and metabolism and drug metabolism genes. So the panels, they include the screening for the genetic variations, which is a Vera code from Illumina. There has been a lot of research going on with the Plavix drug and the warfarin sensitivity. Similarly, gene expression studies are going out for especially for omeprazole concentrations. This is how the future can be, to identify responders and non-responders towards a particular drug. And if they respond well, we can continue the drug. If they are not responding well, alternative medications need to be prescribed for these individuals. So in future, once the next generation sequencing and things get very much in regular practice, we might see a person going to a pharmacist and giving their genetic sequence, and based on that, the drugs can be prescribed. So, and I would like to thank Dr. Vijay Kumar Chennamchetty for giving me this opportunity to present in front of all the CCI team members. I would like to thank Narendra Mithuku, Dr. Ravi Dosi, Dr. N.H. Krishna, and entire CCI team. Thanks so much, and I would like to take any questions. Thank you so much.
What a fantastic talk, Dr. Kumar. In fact, we at CCA, I particularly, we thoroughly enjoyed your talk. There are a lot of, it looks like the future is very promising after listening to your talk, because there may be many therapeutic options that will be available in future. Yes, we do have right now few of the therapeutic options through gene manipulations or related to genetics. But may I ask you one very vital thing which I thought of asking you? What is your inspirational or motivation to study into genetics and become a one of the pioneers in human genetics?
Thanks for a great question, Dr. Vijay Kumar. So my motivation for genetics is a human genome project, which was taken up in early 1990s, where they have shown, like, if we do the whole human genome sequencing of 3 billion base pairs, that could solve a lot of problems, especially, inherited and acquired conditions. And that promise was fulfilled in year 2003, because the whole genome sequencing was completed in 2003. That was one of the major motivation for me. And another motivation is one of my parental uncles in US. He is a surgeon here in Raleigh, New Jersey, North Carolina. He was one of the man who sent me all the literature and the textbooks on genetics. So that was the reason, I moved into genetic field. And some of my lectures also in Vizag and Rajahmundry, they were instrumental in taking up this.
Really, really very inspiring thing. So 3 billion base pairs.
Yeah. 3 billion base pairs.
Right. And here are a few questions that we did receive from audience. You have responded, congratulating CCA for that wonderful and rare topic to for bringing into for a CCA audience. Here is a question which states: are there any genetic variants associated with tuberculosis susceptibility? And what is your take on it?
Yeah, it's yes. There are some genomic studies that took place both in India and worldwide. Data from India shows some of the genetic variants in HLA genes, human leukocyte antigen genes, that are being reported to be susceptible to tuberculosis. And another study which showed was like vitamin D receptor, polymorphisms in vitamin D receptor gene that could cause, they can lead to susceptibility to TB. And there is one called soluble carrier protein 11A, which has been replicated in several populations, not only in India, but several populations in Africa also. It's before it was called NRAP1. Now it is called soluble carrier protein 11A1.
Okay. So that means if we can identify these genes, then we can detect that these population, probably the physicians who are at risk of exposure, healthcare workers who are at risk of exposure to tuberculosis, we can identify them, and then we can warn well in advance that you may be susceptible to tuberculosis. Please be careful, right?
Yes.
That's what.
Yes.
Huh? Right. Yeah. Fantastic. Very, very practical thing.
Practical thing, yes.
Yeah.
So genome-wide association studies are associations. They are not causal. So, people are somewhat need more data on that, Dr. Vijay Kumar. So in future, once the next generation sequencing comes up and the long read sequencing comes up, we will have a definite answers for majority of these susceptible diseases.
So is the science is moving towards to identify these mutations, like inherited mutations, well in advance, probably at a womb level, fetal level, and then we can knock them off as well?
Yes,
What is
yes.
your take?
So now chromosome microarrays have become a standard tool for identifying a lot of genetic disorders prenatally. They are the first line, thing. And a lot of advancements have happened, and many genetic disorders have been knocked out due to that. And now nifty came up, like non-invasive techniques also, not only the invasive prenatal diagnosis, but non-invasive methods are also coming up in prenatal diagnosis. That will help in future to knock down a lot of genetic diseases.
I don't think that is, as of now, is a reality, at least in India. What is the current level of practice of such identification in prenatal level at United States?
So American College of Medical Genetics and American College of Obstetrics and Gynecology, they are recommending CMA, chromosome microarrays, for prenatal diagnosis. So it's a very standard of practice here in US, for high risk pregnancies where we see the families with any genetic disorders. They recommend going for a genetic counseling and getting these tests done.
Okay, so it's not for everyone. Those who are having high risk pregnancies, or those families who have had a high chance of previous genetic abnormalities, genetic issues. Okay, for them it's not a routine for every prenatal diagnosis.
Yes, it is not routine. So for Down syndrome, other things, they do some biochemical testing before, going for invasive.
Yes, right. And you were talking about chromosomal arm aneuploidy, which is a tongue twister, at least for me, not for you. What does that mean? I find it very difficult to understand. Can you please explain?
Yes. So now, we are seeing a chromosome arm, like, some human chromosomes are three types, right? Like metacentric means there are two equal arms. Submetacentric has one short arm and one long arm. And acrocentric chromosomes have one long arm. So in cancers, especially, what we are seeing is chromosome arm gains or chromosome arm losses. So there are certain chromosomes where the arms of a particular chromosome, like for example, 3p deletion means the chromosome arm 3p is deleted in certain small cell lung carcinomas. So depending upon how many chromosomes are lost or gained in a particular patient, the scores depend. Okay. So if a patient loses large number of arms of a chromosome's loss or a gain, then his aneuploidy score can be higher, and the prognosis is poor. If the aneuploidy score is low, the prognosis is good, even with the immune checkpoint inhibitors, like PD-1 and PD-L1.
Right. You explained that in one slide. I do remember. Okay. Well, we can predict the prognosis of a particular cancer based on the aneuploidy score, right?
Yes.
If my CCA team remembers this much, I think that's good enough.
Yeah.
Coming to some interesting questions here. Dr. Keras, very renowned pulmonologist from Young and renowned pulmonologist from Chandigarh, is asking about CMA and exome sequencing available in India also. So she is suggesting, okay, and its cost is around 1 lakh. And what is your take? And what is a CMA? The same thing?
CMA is a chromosomal microarray.
Okay, right.
And exome sequencing is like, we capture the protein coding regions and then sequence that part of the genome.
Okay.
Not the entire genome. Like the entire genome has exons and introns.
Right.
But the exons, we capture the exons and sequence them.
Okay.
Generally, these kind of things are very expensive even in US. So in India, they might be using the same kind of chip and the same techniques. So the cost could be, high. But in coming few years, we might see these kind of things the cost can come down
The more we use, definitely the cost is going to come down.
Yes, yes. But it's a very interesting question.
Right. Really, Dr. Keras, thank you for your input. Dr. Tilagavati Gurumurthy from Tamil Nadu, Chennai is asking, her question is, I have a patient 28 years of age, diagnosed with pulmonary embolism on workup. He had autoantibodies to intrinsic factor. On questioning, 2 family members died of young heart attack. On testing, 2 other family members also had an intrinsic factor autoantibody. Please help me how to detect genetic study. I wish to publish this patient. Can you help me, Dr. Kumar Kothapalli? Any emails? Yes. Dr. Tilagavati definitely will share Dr. Kumar Kothapalli email ID in short while here in with you. And meanwhile, let me listen to Dr. Kumar Kothapalli for his inputs.
So, have factor V been screened in these patients? And the other thing is, gene mutation is very uncommon in India, and a lot of studies have shown zero polymorphism in Indian population. But in Indian cohorts, methylene tetrahydrofolate reductase, which causes hyperhomocystinemia, we are seeing some genetic mutations in Indian cohorts. So hyperhomocystinemia is related with, somewhat is related with this kind of heart problems and rarely thrombotic issues. We can look definitely into the literature and help you out, Dr.
Tilagavati.
Yeah.
Thank you for sharing such a nice case, Dr. Tilagavati. And here is, it's a vague question, Dr. Kumar, but Dr. Harmesh Bhute from Maharashtra is asking, there is some rising genetic burden among patients with emphysema, bronchiectasis, asthma, and COPD. What is your take on it?
Because these are all complex disorders, so environmental factors might be playing a big role when coming to.
You mean that there must be some amount of triggers like smoking, air pollution. They also cause some additional somatic mutations, probably leading to increase in burden of COPD and other diseases like bronchiectasis and asthma.
Yeah, environmental factors, especially allergens and the air pollutants, have been shown to modify the effects of our genes per se. But I haven't seen any kind of somatically driven mutations in these patients, to the best of my knowledge.
Right. Yeah. And another important question, anonymous. How common are Keras mutations among lung cancer patients? Are current smokers are at risk?
It's a very good question, Dr. Vijay Kumar. Keras mutations, higher frequency up to 25% is seen in Caucasian population. Whereas coming to the Asian population, its frequency is between 5 to 10% only. And the data shows like, the frequency of Keras mutation is higher in current smokers and past smokers than the non-smoking individuals. So if we get a patient with, large number of years with the smoking history, we might suspect, Keras mutation in those individuals. Right. Because EGFR is very commonly seen in Asian population with non-smoking history.
Right. So, my dear smokers, please listen, and my dear pulmonologists, though you maybe few of them may be still smoking, please be careful. There is every chance that Keras mutation can occur, and then it can cause adenocarcinoma. And here, the next question is, any PIK3CA inhibitors available for lung cancer. What is this, Dr. Kumar?
PIKC3 is seen in up to 8% of squamous cell carcinomas in the lung. This is again a point mutations, like 3 common point mutations in phosphosidyl inositol kinase pathway,
Okay.
So it is most commonly seen in breast cancers, up to 40%. Inhibitor for lung cancers is not approved yet, but there is one inhibitor called alpelisib. It has been approved for breast cancer patients who are hormone positive and HER2 negative.
Okay. Any are inherited mutations, germline mutations found in lung cancer subtypes as well?
Oh, this is the whole genome sequencing efforts are getting on currently, and I have seen couple of papers on germline lung cancers, very recently in 2020 and 21. There is one paper showing like BRCA1 and BRCA2, which are associated with breast cancer, are being seen in some small cell lung carcinoma patients. And similarly, a gene called MUTYH. It is associated with familial adenopolyposis, like colorectal cancer, a lot of polyps. That gene is also found to be associated in some familial studies with lung cancers. This is very interesting topic moving forward for lung cancer patients.
Right. Thank you, Dr. Kumar, for that insight. Dr. Keras is asking again, please share some information, practical information and clinical scope of epigenetics.
Okay, yeah.
And lead-in factor V is the most common cause in such a young case. The previous case which we have discussed from Dr. Tilagavati, she is suggesting that maybe factor V lead-in is one reason. Dr. Keras, I believe it is, though it may be one reason or most common reason for pulmonary embolism in young onset or thrombotic disease in young onset, but there may be many other causes which, when we evaluate genetically, they show a lot of insights. And as Dr. Kumar explained in detail, so we will send the literature to Dr. Tilagavati regarding further. And Dr. Kumar has voluntarily agreed that he will help in case if any one of us need literature, Dr. Kumar will be happy to help and share with us to the entire CCA team. Thank you, Keras. And let's go to that question on epigenetics clinical role.
So epigenetics is now becoming very popular because epigenetic changes, they won't change your DNA, but they affect how the genes are becoming expressed. There are some studies, especially in Angelman and Prader-Willi syndrome, they are due to the epigenetic modifications, imprinting. Coming to lung disorders, we need to see the literature, what are the disorders that are being affected by epigenetic changes. Even microRNAs are now becoming more famous, for future studies. So, top of my head, I don't know any particular lung disorder that has an epigenetic connection.
Okay. So, of late, the gut biome is playing a very, very important role in manifestation of various or expression of various genes. How to explain this? And is there any good bacteria that help to all the human population to suppress the bad genes, or is there a bad bacteria which is really causing this kind of problem? and how to take it, how to see it in a clinical perspective?
So we need, it's a very interesting topic. I have known one very famous microbe person from Cornell University. She is now the director of Maxwell. They have done a lot of work on this microbe analysis, genomic analysis. So if I take that question in a genetics perspective, I would say, some of the good bacteria might be lowering chronic inflammation, and maybe the genes involved in inflammatory pathways might be downregulated. That is the reason we might be seeing, good effects. And similarly, a bad bacteria which might have an effect on increasing the inflammation, and those kind of things can happen. Why? Because in Indian cohort, we published a paper in 2016 showing one dietary factor called omega-3 fatty acids that can change the inflammatory pathway rapidly. Because in India, now we are using omega-6 rich oils, which are pro-inflammatory pathway, fatty acids. Okay. By reducing that anti-inflammatory effects, inflammatory effects, we can definitely, control the genes that are in the inflammatory pathway.
Thank you, Dr. Kumar. And will current status of precision medicine for single gene disorders such as cystic fibrosis? I think this question you have spoken very well, but for the interest of pulmonologists and physicians who are attending the webinar, can you please explain what are the advantages of such a genetic testing?
Yeah. So in CFTR, if we see cystic fibrosis, that CFTR gene is very big gene. Like Duchenne muscular dystrophy, DMD gene is also a very big gene. With a lot of mutations have been seen in these both genes. In CFTR, like there are 1700 mutations, but not all mutations, they are pathogenic or, they can cause significant phenotypes. But, if we see the CFTR gene, there are few truncated mutations, what we call as nonsense mutations. That means that they prematurely terminate your protein. And those are the mutations that are very dangerous, and no function of the CFTR is found in those individuals. Whereas there are other mutations which are called F508 deletion. It is not as dangerous as the truncated mutation. Right. But by knowing the mutation, now several compounds are being tried to inhibit those kind of mutations. So by knowing the mutation, we could answer at least, in CFTR, there are two approved drugs from FDA, which can help the patients with that particular gene mutation. So, right. If we know the mutation, luckily, if a person has F508 deletion, now there is a medication available for them. Right.
And here, what is the current state of gene therapy approaches for such respiratory diseases? Is there any role of gene therapy?
Yeah. So, UK especially, they have started a gene therapy consortium in 2001. They have tried lentiviral vector-based gene delivery to the lungs in cystic fibrosis patients with great success. So now they are trying the same thing for other pulmonary disorders. But now with the recent advancements of TALEN technology and CRISPR technology, we might see more, gene therapy approaches especially for single gene disorders. So the future looks very promising with CRISPR technology.
You have named two technologies, TALEN and CRISPR, I think, if I'm correct.
Yes.
What are those?
CRISPR is like a gene editing. We can edit the gene. Similarly, TALEN also, you can edit the genes.
So you people are making, I think, the future really promising, and it's something like tailoring work, right?
Yes, tailoring, like tailoring and correcting your genes.
What you want, you take it, you include. What you don't want, you just cut it off and then delete, and you
Yeah.
make healthy babies.
Yes, that would be more dangerous, but it can happen in future.
Really? Okay.
Yeah.
Right. What is practically, in how much time you can see that this kind of vision is a reality for at least most of the problems?
Um,
Like,
some,
like
yeah.
my example is you identify a non-small cell lung cancer, and you can knock off such a gene from the adult, maybe around, take an example, who is a smoker, will make him that to stop smoking, identify this gene, and then make sure that he will be no longer a pro for developing non-small cell lung cancer. Is that a practical reality?
The reality could be good for inherited conditions. For example, if we know, like sickle cell anemia, we know like there is only one mutation which can cause sickle cell trait, or alpha-1 antitrypsin, we know exactly where the mutation is. There, cutting that part and fixing it is very easier than some of the huge deletions or losses that are being seen in cancers.
Right. Is the genetic testing for various these disorders which you have discussed in your talk, like pulmonary embolism, pulmonary hypertension, is it available? If they are available, how to approach or which labs are available in India, or whether we can, if we want to evaluate our patients, whether we can send the sample to US, writing a letter to you. What is the means?
Yeah, for PAH, it's an autosomal dominant disorder, and there is a panel of 14 genes. 12 are already studied, and 2 are experimental genes. Invitae, a company, genetic testing company, is doing that panel in US. For diagnostic purpose, there is no need for any letter from sending to India, but only for the research purpose, we cannot send any DNA out of the country. So for diagnostic purpose, we can send the blood samples out of India to get tested.
Right. Thank you. I think whom to approach? Right. In such case, can we share your email ID to everyone so that they can approach you through mail?
Yeah, I can direct them to the places where the testing is done. Definitely, yes.
Thank you, Dr. Kumar.
But in US, the costs can be very high when compared to the testing in India.
Right.
So, yeah.
Do you think the similar kind of surveys are available in India?
There are some companies doing it in India, but I don't know exactly how much of whole genome things are being done.
Okay.
MedGenome is doing one thing for whole genome in India.
Okay.
There are some in Hyderabad also. My friend is doing only single gene disorders, but not for everything.
Okay. Right. Right. Here, Dr. Ajay from Maharashtra, Nagpur, is asking, recently Dr. Vineet has told us, I don't know who is that Vineet, but Dr. Vineet has told us that 17 ml of blood is drawn from patients, particularly after malignancy or any malignancy, to evaluate prognosis or removal of the malignancies from the body. Such a vague question, I'm sorry. They also said institute like Tata Hospital do not approve this type of blood test or liquid biopsy. What is your take on this liquid biopsy? So liquid biopsy is, to my knowledge, is evolving. There is no gross evidence, but whenever there is a tissue, it's very difficult to access. Example, you have a lymph node which is in difficult to access situation, or a mass lesion in the lung which is not accessible for bronchoscopy close to hilum. but it is not accessible in EBUS or CT-guided techniques, then in such cases, or some patients, they may not be fit for the procedure. Example, EBUS kind of procedure or a radial EBUS kind of cryolung biopsy procedures, they may require at least an hour of general anesthesia, and they may having concomitant other disorders like coagulation abnormalities, where the biopsy is very difficult and it may be life danger. It may carry some life danger. In such scenarios, probably liquid biopsy can be attempted. If Dr. Kumar, please correct me if I'm wrong.
So liquid biopsy, if it gets the tumor sample, then getting an RNA, if it is collected really well, getting an RNA and DNA is now very easy, because RNA stabilizers, are very available everywhere now throughout the world. If we want to do any gene expression studies, RNA can be stabilized, and DNA is stabilized for longer periods. But the only thing is sometimes RNA is not stable in FFP stored blocks. So liquid biopsies, if we get a tumor sample, definitely it can help in getting RNA and DNA things done.
Here is some suggestion regarding availability of genetic testing. As you rightly said, Dr. Kumar, MedGenome is one in India is doing such brilliant things. And one of my colleague has texted me saying that Dr Genetics is also available in Hyderabad, which can help in processing even whole genome sequencing. That's what they said.
Oh, good. I see. So one thing is what I'm getting from my friends, the colleagues in US and other countries also, this the genome sequencing reports are getting extensive, like, several pages of reporting, and most of the physicians are not able to understand, how to make use of such a huge data, given for that patients. My take on that is when we come to the reporting, we should see if the report contains any pathogenic variants. Those are the things which need to be taken care of. But most of the time we find the reports showing like unknown significance or, unknown clinical significance. Those are the things, very hard to answer for the patient, and it confuses the clinician also.
Right. Besides clinicians, example, we give a report saying that you are at risk of Alzheimer's, you are at risk of thyroid malignancy, you are at risk of colon malignancy. Okay, yes. There may be some things, dietary changes or something that you can do on a large scale, but pinpointing solutions are still, I don't think it is available, right?
Yes. Yeah. Predictive medicine, it's very tough to answer.
Yeah. And probably they may end up in repeatedly evaluating, example, repeated colonoscopies, like that.
So if one or two of the family members are affected, then it can give you a good clue or answers. But if there is no family history, then it's not suggestible at this point of time.
Right. And apart from this cystic fibrosis, which you have mentioned, Dr. Kumar, you have mentioned that there are some nonsense mutations and or truncated mutations. Do these mutations have any significance in other diseases which are in pulmonary practice?
It is very specific to that particular gene, CFTR.
Okay, you have mentioned one more thing like Dutchnemus DMD or something.
Yeah. So DMD mutation. Oh yeah, DMD has so many mutations, Dr. Vijay Kumar. It involves large deletions also.
Okay.
So now FDA came up with the two drugs for exon 45 deletion in DMD patients. Like that, DMD has a huge interest now in US, especially with the gene therapy based drugs. Right.
I was going through the your talk, this Trikafta, okay, which you have mentioned, that will be helpful in treatment of F508 deletion of in CFTR gene.
Yes,
So how does these things work? Because for us, we only know, okay, if there is a drug which we administered, that goes either through receptors or enzyme mediated pathways.
Yes.
These also, these Trikaftas also act through similar manner, or what is the line of management in genetic therapy?
Yeah, actually, this F508 deletion, it causes misfolding protein, this mutation. So this Trikafta targets that misfolding and makes the channel open for CFTR patients.
Oh, okay.
Those are the mechanisms where these mutations are trying to help to develop compounds which can help the patients breathe well.
And I'm our chairman trustee, Dr. Krishna NH, has posted huge appreciations for Dr. Kumar Kothapalli for giving us a very versatile talk and a very thoughtful, lot of new things which we have learned today. And there were 1155 logins today across Pan India for our webinar. He was congratulating the team CCA, team Cipla as well. Thank you,
Dr. Krishna.
For Krishna, Anna, thank you so much for that appreciations to our guest speaker today.
Thank you so much, CCA team and Dr. Krishna.
Are there any genetic variations reported in ACE2 genes in COVID-19, and what is its clinical significance? Is there any particular things that we can predict well in advance that COVID-19 cannot create any havoc in a person carrying this particular gene, or if COVID-19 gets affect this particular patient, he can be potentially knocked off? What is is there any data regarding that?
Yes, Dr. Vijay Kumar. There is a lot of interest going on with certain genes, especially which are on chromosome X.
Okay.
Like chromosome X, like ACE2 gene, which is on chromosome X, and TLR7 is also on chromosome X. Both of them, they are not. X inactivation is one of the mechanisms where one X is silenced, right? But these two genes escape X chromosome inactivation.
Okay.
So that is the reason why TLR7, women have 2 copies and men have only 1 copy.
Yes.
That is the reason why it's a very immune gene, like toll-like receptor 7. And some of the data is showing loss of function mutations in TLR7 gene in young men. Especially in 2% of the young men, they are getting severe COVID and they are dying from that.
Oh.
And this is a publication in 2020 from JAMA, initial article in young male patients, and that has been replicated by several others. So we need to be very cautious in these findings, but as COVID is an enigma and we are all learning, these particular genes loss of function, especially if it is causing loss of function, we need to take them really serious. And TLR7 is one such candidate that has been replicated by many people.
So probably what I think as a clinician from India, probably if we identify such genes, maybe in particular set of patients, steroids may work wonders, and immunomodulators, other immunomodulators may cause more harm in particular group of patients. So I think there is a lot more that we need to learn. We know very little amount of genetics, I believe, right?
Even as a genetist, it's a learning curve for me every day because technology is moving so fast in genomic medicine.
So among this, say it's as a common man, layman, I'm asking Dr. Kumar. People say 98% of genes among entire human population is they are common.
Uh-huh.
It's only the 2% or 1% what is that makes you as a different individual. Is that right?
Yes, yes, Dr. Vijay Kumar. Yes, even 1% makes a lot of difference. 1% genomic polymorphisms, they make a lot of difference in
Right.
this 3 billion base pair genome. Yeah.
Our National Secretary, Dr. Ravi Dosi, is asking you how to do research on a topic related to genetics, how to approach it. Please guide us. This looks like a very promising profession in the future as well.
Yeah. So in India, certain organizations like CCMB, they are doing very good genetic research. And even in Delhi and Bombay, there are certain institutes, they are doing really good genetic research. That is the reason why now for COVID, we got this identification of the Delta variant so fast from India, because they have done the full genome sequencing of the SARS-CoV-2 virus. That helped the whole world, getting the Delta variant under control. Especially, even we have seen huge human loss, but due to the sequencing efforts from organizations like CCMB and initiatives from ICMR, we are seeing these sequences being deposited in US databases so that the world learns about them.
Right. Yes, I do agree because though it looks like a very young and budding branch of medicine, but there is enough research that has already occurred, and it's the role of genetics in pulmonary practice is really there's a long way to go. But having said this, whatever it is available, we can use in multiple ways and for the benefit of the nation, research, and patients. And so, Dr. Ravi, Dr. Kumar is saying that probably we must write, at least if we want to do some research in genetics, we must approach CCMB or ICMR or other related institutes. The next question here says, any loss of function in genetic mutations reported so far in COVID-19 patients? I don't know.
Oh, yes. Loss of function mutations, I explained before, like in TLR7, we have seen loss of function mutations.
Right. So, I go a little more depth and then I want to ask you this question. Is COVID-19 virus genetically engineered one? Point number one. Second, if it affects, is there any chances that there is a change in the genomic structure, either DNA or this mitochondrial DNA or somewhere? Is there any chances that, because there's a lot fear in many well-learned physicians as well, the spike protein, once it is injected into the in the form of vaccine or in the form of virus, very active infection, okay, that's it. Some people are thinking that it can potentially change the genomic structure. What is your take on it?
Injecting spike protein won't change because mRNA can't penetrate into the cells, especially mRNA vaccine, the design. It cannot penetrate into the cell of your nucleus, nucleated cell. So integrating into your genome for that perspective is not possible for the mRNA vaccine, that have been approved in US from Pfizer and Moderna. And Covaxin is like an old school method, like they are using old school method.
So vector vaccine, right?
Yeah, vector vaccine. And even Covishield is based on adenoviral vectors, which are being used previously. So doing a damage to your DNA might not be possible with these vaccines, but we never know how long-term effects can show up,
Right.
Uh,
So
and then
you suggest population to get vaccinated or not?
I suggest, I'm a very strong believer of getting vaccine,
So,
Dr. Vijay Kumar, yes. So I have done a lot of, DNA and RNA research on these vaccines. So RNA vaccines, they are, they are not that stable to damage your genome.
okay, right. So do you, Dr. Kirat again asking from Chandigarh, do you consider the outsourcing of genomic study by private labs to China a threat in any manner?
I can't answer that question because, I don't know how the things in China are.
Right.
But in India, in US, we have HIPAA regulations, everything, and it's very systematically done in US. So I'm not that much familiar with the China country.
Right.
So
that's not our core interest. I don't know whether how far artificial intelligence algorithms can help in genetics.
now artificial intelligence is becoming very popular, Dr. Vijay Kumar, especially in lung carcinomas. The images based on the CT images, they are trying to figure out, which image corresponds to which mutation. So, now testing mutation is taking
Remember, you
days.
had a publication, I believe, that miliary metastasis of non-small cell lung cancer favors one kind of existing mutation, right?
Yes. That is EGFR mutation, yes.
EGFR mutation, right. I have read, I think, long time back, maybe around 6 months, 1 year back.
Yeah.
Right. So that sort of inputs can be arrived through artificial intelligence.
Yes.
That can drive us to think about possibility of existing EGFR mutation or ROS mutation or something else, and then thereby directing our patients with a particular targeted therapy.
Yes.
I think we are done with our questions. There are a lot of appreciations for the novel concept. The appreciations are from various core group members, Dr. Atri, Dr. Narayan Pradeepa, Dr. Narender, Dr. Ambika. So various, and the list goes on and on. Okay. And many people also suggested, thanks for giving a nice lecture, which was very clearly understandable to begin with our journey into genetics. That's what the gist of various appreciations.
Thanks so much, CCI team, and I'm really honored getting such appreciations from allied team like you all. So it's a honor to be here. Thank you so much, Dr. Vijay Kumar Garu, for you inviting me and giving this opportunity also.
Right. And thank you, my dear audience, for keeping us engaged for the past 1.5 hours. Thank you, Dr. Kumar Kothapalli Garu, okay, for investing your valuable times for CCA team, and that probably I felt like you are paying back to your nation, teaching and then guiding us, and the technical team, Dr. Mr. Puneet, Vinod, and Cipla. Thank you for your unconditional love. And whenever we need you, you are always there to help us. Thank you so much. And in nutshell, what I understand is there's a large scope in the near future for human genetic, and then there is a therapeutic approach to it, and there is a diagnostic approach to it. and it is rapidly evolving science. With this conclusion, I would like to conclude today's webinar, and next week we will be meeting at the same time, CCI, with a different concept, post-COVID complications and role of thoracic surgery in managing such post-COVID complications. That will be the next week topic. My dear delegates, please stay connected to CCI webinars, and your valuable are always important for us too. If there is any critical analysis, please don't mind, please share with us. We want to improve and then move forward. Thank you. Love you all. Good night. Thank you, Kumar Garu. Thank you.
Thank you so much.